All right. Well, it's a pleasure to introduce Erin Pierce to you guys. I think most of you know Erin. Erin is my own nurse practitioner at Ochsner. She was an infusion nurse at Ochsner before becoming a nurse practitioner. But I often tell people that Erin is a lot more than a nurse practitioner. She has been named the best nurse practitioner for the entire Ochsner health system. She has also been named the best nurse practitioner for the entire state of Louisiana by the National American Association of Nurse Practitioners. But she is also a researcher in her own right. She is PI for first-in-human phase 1 studies. She writes protocols independently, and she even travels the United States to teach other researchers how to write clinical trial protocols. So without further ado, proud to welcome Erin to the stage.
I'm so happy to be here, and I'm really excited that CAGLA invited me to come up and speak with everyone today. We are going to be talking about precision medicine, and I think Dr. Pershing, you did a wonderful job of showing us exactly why this is important. But I really want to focus on why is this important for nurses. I will say this is the 3rd annual CAGLA conference, and every year since I have told Chad Landry, we need nursing content. We need nursing content. We need nursing content. He finally listened to me. So here I am. So I'm going to go ahead and get this started. These are my disclosures, and this is our agenda today. But I think it's really important for us. I realize we're not all nurses in here, but just like Dr. Pershing was saying, but what is precision medicine? I think he gave a great example for it, and it really is providing that right treatment to the right patient at the right time. By doing this, we know that we're able to improve outcomes. We know that we're able to diminish the use of ineffective treatments that may also have side effects, because, right, every drug has a side effect. And it really just allows us to better predict what treatment options are going to actually work for these patients. This is by no means unique just to oncology. Of course, this is a cancer conference, so that's where we're going to focus on it. But it really is advancing in every single field of medicine. So now that we know exactly what precision medicine is, and it's shifting from a one-size-fits-all approach, and we're looking at it and saying, how does this apply to oncology? Where does it start? Well, you already took my one quote fact that I got was that precision medicine started oncology in the 1970s. I do not treat breast cancer, so don't ask me any questions about it. But that's exactly where it started. So we're looking at this, and we know that precision medicine has started to guide our therapies since that time. As you can see, we're looking at testings, targeted therapies, immunotherapies. I mean, honestly, in fact, you can see up here, our guidelines now recommend it. They mandate it. You can technically probably get a lawsuit against you as a practicing provider if you don't do these types of things. In fact, one thing me and Dr. Matran talk about all the time is, if someone came to us and we had to go out on the witness stand and someone said, do you think this is malpractice if you did not perform this testing on an advanced cancer patient? You have to say yes. Like, there's no way around it. And so, of course, our guidelines are backing that up now. So as we know, there's lots of them. It would be prostate, it can be breast, it can be ovarian. We're using it throughout the oncology world. In fact, I think it is so significant that 42% of drugs that are currently in development have included biomarkers in their design. That's only going to continue to grow. So let's talk about precision medicine. I think there's really 3 big buckets that we need to break it down and kind of give an explanation about. I don't know about you, but I didn't learn this in nursing school some many moons ago. For the physicians in here, I don't know if it was there in med school when you were there. So we have to break it down a little bit so that way we all know what we're working towards. So I want to talk about risk assessments first. I'm glad we have our one, she's laughing. our one genetic counselor in there. So, hey, I put you in here. Before a patient even develops cancer, we are now routinely using hereditary screening, and we're getting those patients to our genetic counselors. I have to give kudos to ours. They're fantastic. They somehow can squeeze them in and get them in faster than ever, especially when you really need it. You know, some of these cancers that can occur might be breast, ovarian, prostate, Lynch syndrome. These things we're really are doing is stratifying their risk, and we're able to really give that personalized preventative strategy to that patient. As Dr. Pershing said, it is definitely a not one size fits all. It is lifestyle modifications. It's saying, hey, you know, this looks like you may need to start your testing earlier. And how can we just mitigate the overall risk of developing cancer? With that, it's also important as it not only has implications for the patient, which of course is important, but it also expands to cascade testing. This is something that I use actually on a daily basis at work with my prostate patients. Most of them, and these gentlemen, will say, oh, well, Erin, I don't think I really need that. It's not that big. So instead of asking that, I say, do you have kids? Do you have grandkids? Let's talk about them. Who are they? Tell me about them. You know, I love getting to know my patients. So they'll, start rattling off. And I said, so what happens if I could tell you there may be some implications based on you for them? And that maybe potentially you could help delay them from getting cancer. That's your buy-in. So again, making sure that you're getting your patient to understand that it doesn't help only them, but that it also helps their family. All right, so while we're going to be talking about genetic testing, I do want to highlight two things. One, very obvious, cancer is genetic. But one thing that I think all cancers are not, hereditary, which comes down to my second point. Genetic testing can be done either in two fashions, somatic or germline. I think this is constant confusion, not only for the people in the medical field. I think this is confusion for the patients. I see people shaking their head because it's true. It's how many times do you have to discuss this? This is exactly why, I have part of a poster that I had started up here, but to explain the differences. So there are two main types of genetic testing. First one is somatic. It's not inherited, and it looks at the tumor. It could be either blood or tissue, and you might think of Garden 360, Tempus, Foundation One, any of the above. And again, we're not looking for those inherited mutations, but rather acquired mutations that occur, whether it be from environmental factors, something along that side. Well, I will say that Juvenile did get part of his song correct when she said she got it from her mama. But she might have also got it from her daddy. So moving on to germline testing, I will say, I know, y'all, I came up with that myself. I was so proud. I really was. I was like, oh, that's a good one. So moving on to germline testing, we're looking at those mutations that are inherited and then were passed down through our family. So again, testing maybe on blood, saliva, other different sources. And then some of those examples might be Myriad, Invitae, or Ambry. All right, let's switch over. We're going to look at diagnosis. So from family history to societal economic backgrounds, we know that patients' genetic makeup and their compositions vary, right? Just like that, so does the cancer. So we want to make sure that while we are utilizing this precision diagnostics, we really want to tailor that specific approach to that patient, making sure that we really are giving them that one-size-fits-all approach, leaving that behind and going towards something that is very tailored to them. So two things that I want to highlight, and this honestly, for some people in the room, may be something completely new that you have never heard about. And that is totally okay. I have been blessed with a wonderful mentor, Dr. Matrana, who is here, and no, he didn't pay me to say that, who has really helped lead this type of innovation, especially in Louisiana. And so that is how I'm able to know about it. But again, this is stuff that is just coming and it's only going to expand. So when we're looking at multi-cancer early detection, I will say this is also called pan screening. This refers to the development and implementation, looking at screening tests that really can detect across all single types of cancers. You're no longer looking for one single thing as far as let me draw a CEA and see if we have colorectal cancer, or look at a PSA, it's going to tell me if it's prostate. But we're looking across one single sample that can tell us across the genome exactly what types of cancers are possible. Pretty cool. When I tell patients this and I talk with them, I'm like, y'all, this is like that high tech stuff that like you used to hear about and you're like, yeah, we're never going to get there. I'm like, oh, we're here. Like it's here. I think a prime example of this specifically is the Pathfinder 2 or the GRAIL study, which I will have to say when Dr. Matrana went on the local news, he nearly broke the Ochsner phone system. See, y'all, and overwhelmed our navigator I thought she was going to quit because there was so much interest in doing this. I mean, I think that just goes to show you that they thought that this was something new and novel and they had never heard of it before. And for most people, that is, what it is. But we need to be, as the medical professionals, being there discussing these types of things with them. Another example that we have going on at Ochsner is the Delphi study, and it's helping to determine if through a blood test you can identify lung cancer. I mean, right now I know we have CT screenings, you can do x-rays, you can do other things, but doing this through a blood sample, honestly, is pretty convenient. It's easy and it's cheap for the most part. We'll get to that later. So the goal in doing this is that we want to identify those cancers at an earlier stage. Well, why? Because then they're more treatable, they're potentially improving patient outcomes, and overall, we're going to be able to reduce that mortality rate. So of course, we want to catch it earlier. But there are challenges, just like I've said it was coming. So let's talk about a couple of those. A few come to mind when I specifically think about this, whether it be the validation of specific biomarkers, development of sensitive tests and tests that are specific enough to look at the screening things that we're looking for, potential for false positives. I think that's really gotten a lot of drum recently, is that there is concern because if you do get a false positive, are you going to put somebody through, that unnecessary diagnostic procedure that they may not have needed? But honestly, I think my biggest issue is that it's only analyzing one moment in history at that specific collection of the sample. So it's great for right now, but do we need to repeat it? Should we do this yearly? Should we do this twice a year? We don't know. But these are the things that we will be finding out in the years to come. I also want to point out that financial toxicity and accessibility of some of these tests really needs to be looked at. I think that, here, obviously, I work in New Orleans and I treat an amazing population, but they cannot all afford an $800 test. I literally have patients who come in most recently, and of course I treat GU cancer, so he's telling me, I'm like, okay, did you take your hormone therapy? And he goes, well, I took it once yesterday. I know I'm supposed to take it twice a day. I'm like, okay, well, you took it twice a day, so why did you only take it once? He goes, well, I didn't get money until this morning to be able to eat, and it says to take with food. Y'all, when I'm telling you that was a very eye-opening experience that literally happened within the last couple weeks, it just made me realize how much our patients go through. I think we knew that already, but I mean, that was something else. All right, moving on to MRD, minimal residual disease. I think this refers to a small number of cancer cells that may remain in the body after treatment. despite the patient appearing to be in complete remission, no evidence of disease on imaging. These residual cancer cells are often present undetectable, like we mentioned, from imaging. But if we do a simple test, blood work, that we can say, hey, is there something that can tell us that maybe this cancer never went away, or has it returned? And again, this makes detecting disease and identifying in the very beginning a whole lot easier. It also helps us to be able to assess treatment effectiveness and honestly predict the likelihood of how is that disease going to reoccur. So, very interesting. Who is doing this right now in our market? Well, you can see up there from all those companies, and we might have some of those individuals in here today. Everyone is getting in on MRD. I think it's being talked about more. I hear it more in the news, but everybody wants a piece of it. And why not? The global minimal residual disease testing market size is expected to reach $4.5 billion by 2030. Of course, everybody wants a piece of that. There have been several methods to develop, and especially looking at that. So while some may be very easy and be a blood test, you may have flow cytometry, you might have immunohistochemistry, imaging modalities, and of course, those liquid biopsies. But I think the real question is, what do we do with this? There are very much limited clinical studies that are currently out there, and we need more to guide these clinical decisions. So if we get this information, we have this positive test, do you start treating a number, even though you may not see anything on imaging? That's a whole conversation for another day, because that can get heated. But it makes us think as providers, what should we be doing with this? And I think that's the exciting part, is that we really don't know. To be determined. So lastly, I want to talk about treatment, and this probably is where the biggest area of focus we really know in precision medicine really is. And I honestly don't think that I can even begin to quantify how valuable NGS is specifically to our patients. So as nurses, helping patients to understand how we use this genetic information, not only to guide their treatments, but also their response and what are their toxicities, is super important. So an example of this was just a few years ago when we wanted to start really looking about how did this starting of NGS at Ochsner, provided free of charge, how did that look for our patients? What did it do? So we retrospectively looked at our patients, and y'all, this was old, November 2017 to 2019. But we looked at this and said, let's look at these patients. There was a 44% of those individuals who had actionable alterations or variants of interest, and then 7% of those were matched to clinical trials. So mind you, this again was 2017, 2018, 2019. We've gotten way better since then. But this shows just an example of how this makes a difference to patients, especially, think about how important that might be if this was your mom or your dad. You want to make sure they're having it. So again, I think we all know exactly what NGS is. We've talked about it already. We know the reports. We know it's tissue. It can be blood. I really, though, think they allowed for more precise, targeted therapies, really with higher efficacy. And then they also have lower rates and potentials of side effects. So I think, again, it's discussing that with your patient. One question that we honestly still do not have a definitive answer about is who, what, when, where, why, how do we do this? What does the sequencing look like? Does it need to be done more often than once? We're getting some of those answers. We really are. We're starting to realize some of that. And we're realizing how there's a difference in mechanisms of action that really change the way cancer resistance works. But who should be doing this? We do know that everyone with an advanced or metastatic disease should be receiving it. Who should have it repeated? To be determined. There's still studies that will be coming out that really guide us. Is there certain therapies, certain patient populations that really would benefit from having it? For me, for instance, in prostate, I don't think it's the most crazy idea that every time they progress on a therapy to redraw it, because we know that those results can change. One example, though, we do know is that those individuals who have a poor performance status or some type of rapidly progressing disease, or those who don't really have any standard therapeutic options, of course, we're not going to want to put them through multiple tests. But it may be helpful for some. So let's be honest. You don't know what you're missing if you never try it. So if we're not ordering it, we won't know. So as nurses, providers, nurses are the perfect people to say, hey, I see you haven't run NGS yet on the patient. Yeah, right? You're looking at me because you're like, I mean, it's true. Being that helpful hand, this is not something that is just in physicians' hands. This really is the whole team that is helpful in doing this. So I do want to show a quick case report. We had an 88-year-old prostate patient who was initially diagnosed in December of 2009 with Gleason 6. Not bad, 3+3. He had definitive radiation, but unfortunately in February of 2017 had metastatic disease recurrence. He went through multiple hormonal treatment options, and he had progression. He ended up at this point choosing to prioritize quality of life and made the personal decision, which me and my trainer respected completely, that he did not want chemotherapy. That is totally fine. I will not make you take a therapy you don't want, as long as we're having the conversation where you understand the pros and cons of all the options at the table. So he said, no, I'd rather just get ADT alone, which by no means do I say is the appropriate therapy. I see Melissa's looking at me back there. But his PSA did rise up to 44. So at that point, I think we were in June around 2021, I said, hey, let's get NGS testing on you. This was a couple of years ago, y'all, so be mindful. I said, let's just see what it says. You never know. Well, we got a TMB level back at 13.4 on a prostate cancer patient, which told us that pembrolizumab may just work for him. So we were able to have this discussion with him, talk about the options. He waited. He did. He was not all about it at first. He was still worried about side effects. We gave him one dose. He literally went down to 19.3, so over halved by one dose of Pembro, and then continued to drop down to 0.29 last in May of 2022. So again, that just shows you one test can have a significance for one patient. When we're looking at those genetic variants, we've already talked about inherited and acquired. I'm not going to go over that again. But some of these variants may not be well known. I think most of us here know what benign is, meaning, there's no harmful effects, so to speak. But variants of uncertain significance, what do you do with those? Honestly, we don't really know. But I always tell patients it's good to have it because in the future, when there is something to target that specific gene, we'll know that you have it. Pathogenic describes genetic variants or mutations that predispose those individuals to specific genetic disorders, diseases like cancer. So lastly, I want to discuss pharmacogenomics. That's a mouthful. Or you can call it PGX. And it really is a part of precision medicine that is really starting to take off. This is when we're looking at genes and how it affects person's response to drugs. Combining the pharmacology and the genomics together really can develop effective, safe medications and doses specific to that individual. I think most of us in this room also know that not all patients respond to the same drug. And doesn't all respond to, honestly, to the same dose. So PGX is kind of taking that, changing it around, and instead of that one-size-fits-all approach that we are attempting to leave behind, they're looking at that more tailored approach, literally looking to see, okay, because of this specific genetic mutation or alteration, this is where we want to focus our time on. It's not only valuable for providers because, of course, it helps guide medication selection, but it's also important for patients to help them understand why the changes in their DNA really can make a difference on the type of medicines or, honestly, how they react to medications. Perfect example of this with PGX is a pilot that was done at Ochsner using DPYD testing in colorectal patients. So by looking for this specific genetic mutations in these individuals with colorectal cancer, who usually have worse side effects associated with treatment, they were able to potentially avoid 97.9 inpatient days. That's one gene at looking at that. And I think that's pretty significant. So, also want to point out a fact that I'm beyond proud to say, and honestly something that we can't say very often. I don't know about Alabama, so don't judge me. Which is Louisiana is leading the nation. Honestly. I mean, right? Yeah, I agree. It's not something that we get to say often, in much, maybe every once in a while in football, but we are doing it in precision medicine. CAGLA specifically has been beyond instrumental in advocating for legislation for precision medicine cancer testing, treatment options, and making sure they're mandated for cancer patients in Louisiana. We've had some of those as early as June of 2020, where you can see we were still in the COVID times, where these went into law. Another example, Precision Medicine Testing Bill SB 84, which mandated insurance coverage for all genetic testing for cancer patients with any stage. Something that I also think that we do pretty well is that we have been able to integrate our NGS into the Epic Genomics model, which was the first in the nation. Thank you, Dr. Matrana and team, Kevin. And so now we're actually able to search people's charts for these variants, making it a whole lot easier to go back and investigate when someone maybe had NGS done previously when there wasn't something available for that specific variant. We also have a statewide molecular tumor board, which is held monthly by Dr. Tong Yang, and he's a molecular pathologist where, for instance, providers who are unsure what to do with this NGS, nurses who are unsure about what to do about this NGS, can send their cases and be able to look at it and get some clearer answers. So we reviewed how precision medicine really affects genetic tumor information as far as diagnosis, treatment, planning, and assessing. But what does all of this have to do with nurses and everybody else in the room? How does this make a difference? And how do I make a difference in doing all this? I really think that nurses play an absolutely crucial role in patient education on this precision medicine, really helping to further explain the need and the value of this testing. By being knowledgeable, we can help our providers not only ID these patients, like I said earlier, talk with their family members who have questions. I mean, how many people, something's already released on Epic and they're calling you and they're like, what does this even mean? This is a different language. This is why we need to be all knowledgeable about it. I also think that understanding the unique toxicity profiles of these specific drugs that are coming from this, and implementing appropriate management strategies. I think as APP, I'm pretty good at symptom management. I think Dr. Matrana would agree that if someone's having a side effect in our clinic, he's like, you need to talk to Erin. We as nurses and APPs, we get to spend more time with these individuals. They trust us more, and that is something that we need to use to our advantage. I think we have a ton of things that we have learned that are not from the textbook. And it's from actual years of experience working with these individuals and with these cancer patients. And you just can't learn that in school. I will say that sometimes when you're looking at genetic information, it can get a little tricky. Some people might be a little concerned about giving away their DNA and concerns. So that is something as far as an ethical consideration that we should be mindful for. But I do think that continuous learning is essential, especially in precision medicine. As I told you several different things today that we don't have all the answers for, but we'll slowly be getting there. So I think that's one of the things I love most about oncology is we really do get to keep learning. All right. One more. Hold on. Oh, man, you already saw it. All right. So last but not least, I think this is probably one of my soapboxes. So as nurses, APPs, let's continue to get together, whether it be conferences, meetings, wherever it is, share knowledge and ways to be more innovative. But more importantly than that, get involved. This can be done on a local, state, national, international level. I honestly know friends on every single different level I just mentioned and who make a difference. We have a very unique and a different approach to patient care than our other colleagues, which is not necessarily a bad thing. It should be embraced and it should be utilized. And I think that not only are we needed to do this, but we're absolutely essential in transforming the landscape of cancer care, and we should be integrated in every single part. We may not be able to cure every single patient, and honestly, that is probably one of the hardest parts of our job, but we are able to bring hope and be able to heal and help them to understand what they're going through by this horrible disease. And honestly, with every discovery that we make, each breakthrough, we move a little bit closer to where maybe the C word is not so much feared, because hopefully soon, within next coming years, decades, we'll be able to say, oh, it's just cancer. We got a cure for that. All right. Thank y'all.